My name is Carlos Vargas Ramos. I am the Centro de Estudios Puerto Ricanos, Director of Public Policy, External and Media Relations, and I will be serving as your Masters of Ceremony this afternoon for COVID-19 and Puerto Ricans, a webinar that examines the unequal impact of the COVID-19 pandemic on Puerto Ricans and the Hispanic population in general. On behalf of Centro and our co-sponsors, I welcome you. 1 year into this devastating worldwide epidemic, we have convened researchers who are able to present data on how Puerto Rican communities in the United States, as well as in Puerto Rico, have been affected along social and health dimensions. We will share a total of 4 presentations this afternoon, along with the demonstrations of a data tool, a dashboard, that we believe will be useful for researchers, practitioners, journalists, and the population as a whole. Before we start the program, I would like to acknowledge and thank our co-sponsors in making this event possible. This webinar is a collaborative effort of the following institutions and initiatives: the University of Massachusetts at Lowell, the Harvard's T.H. Chan School of Public Health and its Puerto Rico Observational Study of Psychosocial, Environmental, and Chronic Disease Trends Initiative, the University of California, Los Angeles Latino Policy and Politics Initiative, and its Center for Neighborhood Knowledge. I therefore would like to ask the directors to offer us a few remarks from UCLA. We have from the Latino Policy and Politics Initiative, we have Rodrigo Dominguez Villegas, who's going to address us momentarily. Adelante, Rodrigo.
And thank you for the opportunity to join a robust conversation with an all-star group of experts about the unequal impact of the COVID-19 pandemic on Puerto Ricans and Latinos in general. As you mentioned, I'm the Director of Research at the UCLA Latino Policy and Politics Initiative, which was launched with the belief that research and data could be leveraged as an advocacy tool to drive effective public policy. The Latino Policy and Politics Initiative utilizes a multi-pronged approach of research, mobilization, leadership development, and advocacy to ensure Latinos and other communities of color have a seat at the decision-making table and fair opportunities to thrive. Amid COVID-19, others finally realized how essential Latinos are to power our economy and our democracy. Not only have Latinos done the work to get us through this crisis, but Latinos and other communities of color also protected us all by voting in record numbers, restoring decency in the White House. Our research shows that Puerto Rican voters provided key margins in Pennsylvania and other states for the election results. Yet, unfortunately, we also learned that, though essential, Latino communities appear to be disposable for our elected officials. Today, we will discuss research conducted by experts that tells us an unfortunate and undeniable story. Latinos have borne the brunt of the pandemic with their health and finances, and yet they continue to be excluded from most relief, including access to vaccines. As we begin to imagine a path toward recovery, all of us will continue to place a necessary spotlight on Latinos, highlighting our challenges and our wonderful diversity. In this unique moment of advocacy and hope, we need all hands on deck, and today's webinar will highlight that understanding Latino communities is an essential part to have a successful, just, and equitable recovery. Thank you all.
Thank you, Rodrigo. And next, also from UCLA's Luskin School of Public Affairs, we have Paul Ong, Director of its Center for Neighborhood Knowledge. Paul, you have the floor.
Good afternoon from Los Angeles, and thank you. We're honored and privileged to be part of this important webinar on, I think, the major crisis that we have faced in generations. New York City has a warm place in my heart. My wife was born and raised in New York City. I've lived off and on in New York City for 3 years, and the tragedy that we're seeing, both as a public health crisis, but also as a problem in terms of economic, housing, employment, These are things that we need to address and understand deeply. I very much look forward to the day when I am able to travel to New York City, get back there once again, and get to see my friends and colleagues face to face. But I think this webinar is a step forward in terms of the recovery. And again, thank you for inviting us to participate in this.
Next, we have Luis Falcón, who is Associate Director of the Center for Population Health at the University of Massachusetts Lowell, who this afternoon will also serve as moderator of the presentations by Edwin Melendez, Kelsey Mangano, Josimir Matei, and Natalie Rios. Adelante, Luis.
Thank you, Carlos. Good afternoon to everyone. My name is Luis Falcón, and I serve as the Dean of the College of Fine Arts, Humanities, and Social Sciences at the University of Massachusetts Lowell. I also serve as the co-director of the Center for Population Health at UMass Lowell. Doctors Catherine Tucker and Sabrina Noel are the other two co-directors of the center. The center is an interdisciplinary collaboration among dozens of researchers from 4 to 5 different universities in the greater Boston area. The center has been around in different incarnations at 2 different universities for well over 15 years. And our largest initiative to date has been the Boston Puerto Rican study on health disparities. This particular study, funded by the National Institute of Health, is now in its 4th wave of data collection from what initially was a cohort of 1,500 Puerto Ricans in the Boston area. We have followed them for more than 15 years and interviewed them at 4 different times, which has provided us with a wealth of information to essentially try to understand health disparities among Puerto Ricans, particularly when it comes to comorbidities like cardiovascular disease, obesity, hypertension, nutritional deficiencies, and psychosocial stress in general. I want to thank the Centro for inviting me to moderate this panel, and also for their numerous efforts at documenting the health disparities experienced by Puerto Ricans, wherever they be located. Now, I have the pleasure of introducing a longtime friend and colleague, Dr. Edwin Melendez, an economist by training. Dr. Melendez has a lengthy and highly productive career as a researcher, as well as an advocate for the interests of the Puerto Rican population and other Hispanics. Edwin currently serves as the director of the Center for Puerto Rican Studies at Hunter College, and he will present highlights of findings from the COVID dashboard developed by the Centro. Edwin?
Thanks to all for joining us. The fact that the pandemic has impacted racial and ethnic minority groups in the United States disproportionately is very well documented. Yet, Blacks, Asians, and Hispanics are not monolithic. Within these pan-ethnic groups, the pandemic is having unequal impacts across age cohorts, geographies, and social contexts. The key question is not if, but by how much. The webinar examines the role of existing underlying disparities in health and social conditions contributing to unequal outcomes among Hispanics when compared to other racial and ethnic groups, and of Puerto Ricans when compared to other Hispanics. While aggregate group comparisons, say between whites, Hispanics, and Blacks, are possible because the data is disaggregated for these groups, very rarely data at the local and state levels are collected or disaggregated for subpopulations and by neighborhoods within these major racial and ethnic groups. The existing national study, the Census Household Pulse Survey, measures household experiences during the coronavirus pandemic. However, this survey does not currently have a sample available large enough that allows disaggregating of major racial and ethnic groups to assess differential impacts within these major groups. Today, we're fortunate to have researchers in the panel that have collected data for the impact of COVID on Puerto Ricans in Boston and Puerto Rico. Dr. Kelsey Mangano will present preliminary results from the Boston Puerto Rican Health Study, and Dr. Josimir Matei will present preliminary results from the Puerto Rico COVID study. The lack of available data for intra-group comparisons has led to the use of indirect approaches to measure unequal impact of the pandemic on population subgroups. We are fortunate to have with us an expert on how built environment inequalities affect health outcomes, and she has experience in public health research in New York City. Ms. Natalie Rios will present results from the COVID-19 Equity Research Initiative of the Center for Neighborhood Knowledge at UCLA. This study uses bivariate correlations at the zip code level to examine COVID death and vaccine disparities within the Hispanic population in New York City. At Centro, we have built a COVID-19 pandemic dashboard inaugurated today and open to the public, where users can examine data and discern patterns of disparities between Hispanics and other groups, and with Hispanic subpopulations. My colleague at Centro, Ms. Jennifer Hinojosa, Research Associate and Data Center Coordinator, will give us a tutorial on how to use Centro COVID Dashboard for local analysis impact a little bit later on. Using this data and analysis tool, I would like to take a couple of minutes to highlight some of the differences uncovered when we examine the impact of the pandemic on different racial and ethnic groups. The health outcomes variables include in the dashboard, as you can see, COVID infections on the upper left hand of your screen, and COVID death. Soon we will add vaccinated adults and vaccination hesitancy. The dashboard also includes the COVID Community Index. The CCVI, as it's referred to, is an index that integrates social and health determinants to assess the impact of COVID. The social determinants are based on the US Census Social Vulnerability Index that include variables pertaining to socioeconomic status and vulnerabilities. The health determinants include epidemiological and healthcare system, structural and systemic factors. That will be, the health determinants will include both epidemiological, which are things like chronic conditions, and structural, which include disparities in the health system. Now I want to turn my attention to the social impact indices. Social impact indices are various, and there is an aggregate measure of them. They measure the housing cost burden, overcrowding, economic vulnerability, food insecurity index, digital divide index, and social impact risk factor. Using the dashboard, we can estimate the following impact measures, right? When you look at the overall social impacts, we compare that to the national, which is 500% or 50%, because it's normalized so that all the counties are aggregated, and therefore the mean of that aggregation is from 0 to 1 is 50%. But when you look at the states where Puerto Ricans are aggregated, you can start seeing some of the variations that are induced by the location of Puerto Rican population in these various states. The states that are included here are explained below. But now I want to refer briefly to Massachusetts and New York, because this is contextual for both of the presentations that we're going to hear momentarily. Not to our surprise, those of us who understand Massachusetts understand why it is that the social impact risk index is so high for the Puerto Rican population in this state. Why? Because they're concentrated in Holyoke, Lowell, Lawrence, Chelsea, and parts of Boston that have high vulnerability index. By comparison, New York is about the median nationally. And you can see that in other dimensions, for example, housing affordability, the overcrowding, economic vulnerability, that means the impact that the pandemic has had in different occupations, and the digital divide is more pronounced in Massachusetts than it is in New York, though New York still have high economic vulnerability and so forth. When we look at the risk exposure index, which is simply a measure of given the distribution of the population in all these counties, and all these counties have different social vulnerabilities associated with location in those counties, what is the risk that these populations are exposed to? So here we can compare the various groups, and you can see that Puerto Ricans have a very high exposure to social conditions in the locations where they are distributed throughout the country. In Massachusetts, that coefficient of 0.90% is even higher than the overall average for Puerto Ricans in the selected states where they are located. Same thing for New York. So there is something going on in these localities in terms of the comorbidities, in terms of the infrastructure for health systems and so forth, that create disparities in what we observe is the exposure of these groups to the social impact of the pandemic. And now I just want to conclude. All this is going to be available to you in our website. I also want to direct you to other resources that we have in our website. This report was produced early on during the pandemic, comparing Puerto Rico impact based on the data collected by the census to other locations throughout the United States. We also have conducted several webinars in relation to the impact of COVID and the way to have access to services and so forth. All of these are in our web pages. All the presentations are recorded, and you're free to look for the topics and themes that you're most interested. So let me conclude by thanking all the panelists, all the work that they have done, my colleagues in the centers, Rodrigo, Luis Falcón, and Paul Long, for their generous support to our effort, to all the staff that put this webinar together, and to all the participants for sharing your time with us.
Thank you, Edwin, for those remarks. First of all, I want to highlight the fact that we find ourselves in a very unique situation. As social scientists and epidemiologists, we're trying to understand the consequences of a global catastrophe while we're still very much in the middle of it. So this is not your typical challenge. So today we have three interesting presentations that attempt to outline an initial sketch of how the pandemic may be disproportionately impacting minority groups, in particular Puerto Ricans. So our first speaker is Dr. Kelsey Mangano. Dr. Mangano is currently an assistant professor in the Department of Biomedical and Nutritional Sciences and affiliated with the Center for Population Health at UMass Lowell. She is also affiliated with the Center for Microbiome Research at UMass Medical School. Last year, Kelsey received a COVID supplement from the NIH to examine COVID-related questions with a cohort of Puerto Ricans currently being followed by the Center for Population Health. Kelsey?
Thank you for the opportunity to present data from the Boston Puerto Rican Health Study. My name is Kelsey Mangano. I'm an assistant professor of biomedical and nutritional sciences and a member of the Center for Population Health at the University of Massachusetts Lowell. The ideas, development, and data supporting today's presentation are a major team effort. Therefore, I would like to acknowledge and thank my collaborators listed on this slide. The primary objectives of the current study are twofold. First, to examine the knowledge, attitudes, and beliefs of COVID-19, including perceptions of preparedness and impact on current social resources among 500 Puerto Rican adults from the greater Boston area. Secondly, to quantify the impact of COVID-19 on changes in psychosocial outcomes, including anxiety, depression, perceived stress, and loneliness within the same cohort of adults. The Boston Puerto Rican Health Study is a population-based longitudinal cohort of Puerto Rican adults living in the greater Boston area, aged 45 to 75 years at baseline. In brief, baseline interviews were conducted in participant homes between the years 2005 to 2009. Multiple waves of follow-up have since been conducted. The most recent follow-up study, highlighted here in yellow, was conducted between the years 2018 to 2019. Since then, Since that in-person interview, we have been completing phone interviews to stay in contact with our participants and to ask them to participate in our COVID-19 study. Today, I will be presenting preliminary results from our discussions with participants during the pandemic. Reported data in the current talk related to self-reported health, social network, anthropometrics, lifestyle, and diet were pulled from the most recent in-person interview completed between 2018 and 2019. As mentioned, participants who completed an ancillary study between 2018 and 2019 were asked to participate in the current COVID-19 supplement trial. The current study is being carried out in 2 phases. Phase 1 is complete. It involved an initial phone interview scheduled between June and October of 2020. We completed a total of 505 phone interviews, and the purpose of these calls was to assess exposure, actions, and diagnosis of COVID-19, in addition to assessment of social support, medical care, and food security. The second phase of the study is ongoing. It is comprised of a follow-up phone interview, which just started just this past December, and to date, we have completed 325 interviews. The purpose of phase 2 is to quantify changes in health from phase 1 and to further assess psychosocial outcomes, including anxiety, depression, and loneliness that may be associated with the pandemic or other related factors. This figure shows the participant flowchart and self-report of health. There were 7 deaths reported due to COVID-19, and these were reported by family members, representing approximately 1.4% of our contacted population. Of the 505 interviews, 497 were complete in all sections and included in further analysis. 21 participants reported testing positive for COVID-19, and of those who reported testing positive, approximately half were hospitalized due to the disease, with an average length of stay of 41 days and a range of stay between 2 and 60 days. At the time of interview, only 47% of those reporting testing positive with COVID-19 also reported returning back to their normal health. For those who reported return to normal health, the length of time to return was reported anywhere from 0 to 45 days. This table depicts participant characteristics for the total sample in light blue, and then separate for COVID-19 positive patients and non-disease participants in the gray area. P-values correspond to tested differences in factors between COVID-19 positive and non-diseased participants. The majority of participants were contacted to answer questions related to COVID-19 within approximately a year and a third of their last in-person visit. The sample is majority female with less than an 8th grade education, generally obese with a high prevalence of chronic disease. We observed a significant difference in self-report hypertension between COVID-19 patients and non-diseased patients, where 100% of COVID-19 positive patients reported having hypertension compared to 82% of the non-COVID sample. This is a continuation of the descriptive table. There was a slightly higher reported low food security rate among COVID-19 positive participants at a rate of 10% compared to a rate of 4% in non-diseased participants. Household composition and self-reported use of nutritional supplements were similar between non-diseased patients and COVID-19 positive patients. The table shown here shows self-report actions taken to reduce COVID-19 exposure among the total sample in the light blue, and then self-reported actions taken to reduce COVID-19 transmission among COVID-19 positive participants in purple. Overall, the total sample reported high compliance with actions to reduce COVID-19 exposure, including regular hand washing, staying 6 feet apart from others, avoiding large gatherings, wearing a face mask, and following government guidelines to shelter in place. Participants who reported having COVID-19 also reported high compliance with government guidelines to reduce disease transmission. We are greatly concerned regarding the potential long-term health issues our participants may face due to COVID-19 and factors surrounding the pandemic. Last summer and early fall, only 21% of adults in our study reported being able to obtain their usual medications, and 20% reported not being able to afford routine medical care. In addition, only 13% of the sample reported attending their regularly scheduled healthcare appointments. This table depicts characteristics between the 21 COVID-19 positive cases and a matched cohort of 84 controls. We matched participants on their age, sex, and body mass index. Overall, there were no observed differences in food security, living alone, language acculturation, alcohol consumption, multivitamin or mineral use, current smoking, or prevalence of self-report disease between cases or controls in this cohort. We are currently carrying out a follow-up interview with more extensive questionnaires related to stress and other coping measures that may have occurred during the COVID-19 pandemic. With this data, we will evaluate how access to care, access to food, and other psychosocial measures may have changed over time due to the pandemic and other related factors. Thank you for your attention, and I look forward to today's discussion surrounding this important topic.
Thank you, Kelsey. I have a question for you. I want to ask you, well, actually, two related questions. I want to ask you a little bit to speculate about how you think the results from your study will change or strengthen once the data collection is completed. And two, to point out, well, the cohort that has been followed by the BPRHS has now undergone 4 waves of interviews with participants aged 45 to 70 at baseline. And there has been some attrition, but also significant mortality. We have lost a good number of folks to participants to mortality. How do you think this could be shaping some of your results?
Thank you so much. Those are excellent questions, and I really appreciate the opportunity to present here today and to answer these questions. To answer Dr. Falcón's first question, in regards to how our results may change now that we're continuing follow-up interviews since just this past December, just the past couple months. We anticipate that testing, as it being now more widely available, there being less stigma surrounding testing, its ease of use and accessibility may change the rate at which participants can report being tested for COVID-19. There were far fewer people last year reporting having testing due to its lack of availability, lack of understanding surrounding the testing, which has since changed in the past 8 to 12 months. In addition, there are more resources available. Many of our participants have reported being vaccinated, and I think that is due to the unique aspect of the Boston Puerto Rican health cohort. They are predominantly now an older cohort over the age of 75. This age group has been far reached compared to other younger cohorts, and I think that their vaccination status and knowledge surrounding the pandemic may induce changes now in their responses regarding their modes of action surrounding reduction of risk exposure and reduction of transmission. So I think education around the topic may have increased in our specific cohort, which leads me to your second question, Dr. Falcón, in regards to the fact that this is a very unique cohort in that, again, mostly aged adults that have been followed for 15 years by a very intricate and well-connected research staff that really cares about our community. The 500 or so participants who are left have survived the aging process and other hardships, and therefore there may be, although a community with high risk of chronic disease, the participants we are now interviewing may have lower rates and lower incidence of chronic disease within this smaller cohort that we've been able to stay connected with. And the last thing that I'll mention is we have found through the interview process and also a little bit through these follow-up interviews we're completing that there seems to be a higher level of social connectiveness in this cohort of older Puerto Rican adults. So there seems to be a greater measure of resiliency among this cohort. And we think it could again be due to the fact that they have a tight-knit social network providing them, many of them reported having feelings of support the 21 individuals who had COVID-19, all 21 reported having somebody to talk to, having somebody who was regularly checking in with them. And I think that's somewhat unique to this cohort, again, who may have a higher rate of resiliency and due to social connectiveness. So I hope that answers your questions.
It absolutely does. Thank you, Kelsey.
Thank you.
Really exciting. Look forward to hearing about the findings once you complete the data collection. Our next speaker is Dr. Josimer Matei. Josie is the Donald and Sue Pritzker Associate Professor of Nutrition at the Department of Nutrition at the Harvard T.H. Chan School of Public Health. She investigates genetic, dietary, and psychosocial determinants of cardiometabolic diseases in racial, ethnic groups and underserved populations. Josie is the principal investigator of the PROSPECT study funded by the NIH and currently out in the field in Puerto Rico conducting an island-wide survey. Let me point out that the PROSPECT study has shown some resilience because it survived both Maria and it seems to be surviving COVID-19 at this point. Josie?
Good afternoon. Thank you to Centro for inviting me to present today. I am Dr. Josimer Matei, currently at the Harvard Chan School. Our research group studies the lifestyle and psychosocial risk factors of chronic diseases among Latinos in the United States and in Puerto Rico. Today, I will be sharing results on the emotional health among adults in Puerto Rico during the COVID pandemic, collected from the PROSPECT cohort. And we will be specifically focusing on feelings of depression, anxiety, and stress. To begin with, we must note that emotional health was concerning in Puerto Rico even before the pandemic. In 2015, we conducted a cross-sectional study among nearly 400 adults in the San Juan metro area and asked about emotional health. 23% reported having anxiety at the moment, 18% reported having depression based on a given medical diagnosis. That is 1 in 5 adults struggling with negative emotional feelings. More astonishing was the fact that more than half of the participants had a score indicative of having likely depression according to a symptoms-based questionnaire. The contributors to emotional well-being are multifactorial. In Puerto Rico, social and individual stressors are quite widespread. Unemployment rates are hovering the 15%. Socioeconomic limitations prevail, with nearly half of the population experiencing poverty. The last few years have been defined by political and social instability, high crime rates, violence, and of course, massive natural disasters. So Puerto Rico was already in what I call a pressure cooker. And then the COVID-19 pandemic hit. So this is where we had a natural opportunity to track emotional well-being in the island. The PROSPECT cohort is a longitudinal study on lifestyle and psychosocial risk factors in Puerto Rico. The study is conducted across the whole island and started in 2019, pre-pandemic, with the goal of recruiting 2,000 adults. Our initial recruitment and intervention strategies were done in person by visiting households to invite potential participants who came into one of our 55 partner clinics for an in-person interview and biological measurements. And that included a full battery of mental health questions. In March 16, 2020, we had to stop all protocols due to COVID-19 closures. Later in August 2020, we resumed PROSPECT using alternative methods for with safety precautions and for phone or video calls. But in that period in between, we took an opportunity to probe COVID-19 related factors. In April 15th, we started calling participants to ask questions on COVID-19 exposures, symptoms, testing, and diagnosis, as well as questions on emotional, mental health, food access, medical diagnosis, and changes in lifestyle habits during the pandemic. We used proxy single item questions for emotional health that were previously validated against full symptom scales for the sake of brevity. Participants responded at the first contact and those responses were established. Then we called them weekly until July to assess any changes from that initial call. We had 566 PROSPECT participants as of March 16 when we paused the study. and 86% of them completed the baseline COVID-19 survey. And that is the data that I will show today. Nearly 75% of participants follow up for at least 5 weeks, and 42% had 10 or more weeks of surveillance data. There were minimal changes tracked over time. Fortunately, only one participant reported testing positive for COVID-19. So sharing some results, first we observed that the majority of participants felt informed on COVID and were following the physical distancing guidelines while still trying to stay socially connected through other channels. However, fears remain, mostly a fear of getting or dying from COVID. I mentioned that only one participant reported a positive COVID test, yet, shown in blue, we observed that 41% experienced at least one COVID-19 symptom, either major or minor, 4% reported a major symptom, 20% sought medical care because of these symptoms, and in other COVID-related factors, 22% reported losing their job due to COVID, and 14% reported limiting their food due to lack of money. So our next question was whether any of these behaviors and consequences were related to emotional well-being. First, we observed a significant increase in likelihood of feeling anxious from socially distancing. Now, I find that interesting because we originally thought that people who distanced more might have felt more safe and thus be less anxious, but it seems that the opposite was happening. We also observed that reporting any COVID-19 symptom, major or minor, was associated with a doubling in likelihood of feeling anxious, depressed, or stressed. Being afraid of getting COVID-19 was nearly triple the odds of feeling depressed. Now, this is important because we had very few participants reporting major symptoms and just one confirmed case. So the emotional distress came from minor symptoms or even just the fear of getting them. Lastly, we noted 3 times the odds of feeling anxious and 4 times the odds of feeling stressed for those who had to limit food intake. So COVID may have exacerbated food purchasing power and access, which increased anxiety and stress. But what about changes in emotional health? Well, since we had pre-pandemic data in prospect, we were able to identify adults with pre-existing emotional symptoms. First, among those without prior symptoms, there was a slight increase in anxiety and interesting, fewer reported feelings of depression. That is something that we're looking into more deeply. However, for those who had pre-pandemic emotional distress, additional feelings dramatically rose post-pandemic, suggesting a worsening in prevalence of adverse emotions. Further confirming this, after adjusting for socio-demographic factors, feelings of anxiety, depression, or stress were between 2 to 3 times higher for adults with pre-pandemic emotional distress compared to those without symptoms. So what are the takeaway messages? First, emotional distress remains a persistent concern in Puerto Rico. COVID-19 fears and consequences increased emotional distress, and adults having these feelings before the pandemic had worsening emotion during the pandemic. This raises the issue of remaining attentive to emotional health all the time. I include in the bottom a couple of comprehensive articles on evidence-based strategies to address mental health with multi-level approaches. I encourage you to check this out, but I would like to highlight a couple that might work well in Puerto Rico. First, a robust constant screening system for mental health, remote and in-person help services, such as the Linea Paz that operates in the island, and training stakeholders on how to respond to mental health crisis and avoiding stigma. Prospect was timely in collecting data to support these strategies, yet we need to ensure that these are applied at all times, not only when the pressure cooker is on. None of this work would have been possible without the effort of our phenomenal teams in Boston, our main partners in the island at FDI Clinical Research, and our collaborators at UMass Lowell, and the funds that have subsidized our projects. Thank you very much, and I will be glad to listen to your comments and questions.
Thank you, Dr. Matei, for really exciting presentation, and I truly appreciate your effort at making explicit connections of how the pandemic may impact psychosocial stress in ways that are not reflected when we look at the standard data, number of infections, number of deaths. At the end of your presentation, you tried to link your findings to potential policy solutions. So I know that this is all imperfect at this point, but based on your understanding of the problem, how would you prioritize possible interventions and make the case to policymakers about how they could begin to address the challenge of stress and depression symptomatology among the Puerto Rican population?
Thank you. That's an excellent question, Dr. Falcón. And my opinion is that this is such a pressing issue that we truly need to tackle it at all levels. Interventions policy is definitely a wider scope and a catch-all level to start with, but we should definitely consider this, including in healthcare, individual-based, and even at the community level. To answer your question for possible interventions, something that has been shown extremely well successful, especially during the pandemic across the globe in multiple countries, is continued screening at clinics and even through phone visits and telehealth to help identify the people who are showing emotional distress or who are at risk for such. So that is number one, and we have to continue that. And these programs are especially valuable for capturing vulnerable groups who are more likely to experience distress, but less likely to be screened in regular settings, such as low-income groups, older populations, and adolescents. And there are very quick and easy validated screeners that we can implement in clinical and community settings. So this is very feasible to do. Now, of course, I have to mention that the key here is to link these screening services to sustained mental health services. We can just not leave the people hanging after a potential diagnosis. Now, the second intervention that has really good potential, and this is especially important for the tight Puerto Rican community, and something that Kelsey previously alluded to, is the social connection programs. There's a very strong social connectivity and social network in the island and among our Puerto Rican community, so we can definitely take advantage of that. Community centers, volunteering groups, even walking and religious groups, these are very well-established social supports and network systems that can blunt emotional distress. And finally, just to address your question on policy, first, if we keep collecting the data and making sure that we screen our population correctly, we can push further for policy changes with legislators and policymakers. So that's important to have that data to support this. But in terms of what to tackle first, my recommendation on what has shown a lot of results, positive results, is to tackle the upstream or the structural drivers of emotional distress. So some of these I alluded to in the presentation. First, stronger policies on crime and violence. Huge driver of emotional distress and something that we can strengthen. Improvements on the built environment and financial assistance, especially for food security. We saw that people who had food insecurity had more emotional distress. So providing assistance for food security and for safe housing are key. Now, super quickly, lastly, on all levels, something that we have to keep on working is to ensure that mental health is seen as a priority rather than as a stigma. So I hope that answers your question.
Thank you very much, Dr. Mate. So our next presenter is Ms. Natalie Rios. Natalie is a graduate student researcher at the Center for Neighborhood Knowledge at UCLA. She is currently pursuing a master's of urban and regional planning degree. She holds a BA in sociology from the University of Chicago as well. She has experience in public health research, working on projects that address gaps in care for Blacks and Latinx individuals living or receiving care in the Bronx. Natalie will present preliminary findings from an ongoing research project at the Center for Neighborhood Knowledge. Natalie?
Hi, my name is Natalie Rios Gutierrez. I am a researcher at the Center for Neighborhood Knowledge at UCLA. Today I'll be presenting on the pandemic impacts on Hispanics, New York City COVID-19 death and vaccination. This research was done by the Center of Neighbor Knowledge in collaboration with the Latino Policy and Politics Initiative at UCLA. My co-authors include Dr. Paul Ong, Lauren Harper, and Dr. Rodrigo Dominguez Villegas. So for a little bit of context, as I'm sure all of you are aware of, NYC was the first major epicenter of COVID-19 in the United States. And as we know from news articles and previous research, communities of color, particularly Black and Latinx communities, were disproportionately affected by the coronavirus. So this led us to ask a question, are Hispanics getting vaccinated fairly? To answer this, we compare the citywide and neighborhood level patterns of COVID-19 death and vaccination rates among non-Hispanic whites and Hispanics in New York City. We used 3 different data sources, which included data about coronavirus from the New York City Department of Health from March 11, 2021, data from the Household Pulse Survey from January to March, and as well as demographic data from the American Community Survey. Additionally, to get to our question of whether or not Hispanics were getting vaccinated fairly, we wanted to look at the differences between death rates and vaccination rates. So we normalized the death and vaccinated data. So that means we created Z-scores and then subtracted vaccination rates from the death rates to get our vaccination gap. I'll explain a little bit more about that during our results. So first, as I mentioned earlier, we looked at city level results from COVID-19. So we found that despite of high levels of COVID-19 outcomes, so that means high levels of cases, hospitalizations, and deaths, vaccination among New York City Hispanics is really low. So Hispanics are 1.4 times more likely to have a positive case of COVID-19. This number is likely under counting the disparities between non-Hispanic whites and Hispanics, since Hispanics likely don't have the same access to testing. As we can see for hospitalizations and deaths, Hispanics are almost twice as likely to die or be hospitalized from COVID-19 than non-Hispanic whites. In comparison, Hispanics are 3/5 less likely to be vaccinated from COVID-19. So in addition to looking at New York City Department of Health data, we also looked at responses from the household survey. So in these, we also find the same disparities in vaccination rates between Hispanics and non-Hispanic whites. But we also found that these disparities persist regardless of the age of the person. So we find that Hispanics who are older than 65 are still getting vaccinated at lower rates than non-Hispanic whites of that same age. And we also find that Hispanics with at least a bachelor's degree are getting vaccinated at lower rates than non-Hispanic whites. We also looked at reluctancy to vaccination among people who haven't gotten vaccinated, and we find similar levels of reluctancy between Hispanics and non-Hispanic whites. So we don't think this is what's causing the disparity in vaccination. So in addition to looking at city and regional demographics, we wanted to study the graphical patterns of vaccination and COVID-19 death. So overall, we find that neighborhoods with the highest levels of death rates indicated in dark brown on the map on the left are also the neighborhoods with the lowest vaccination rates indicated by white on the left of the screen. We further examined neighborhood level disparities by looking at neighborhoods by racial minority. So that can be seen on the photo on the left. So the dark purple indicates neighborhoods with a Hispanic majority, and dark yellow indicates neighborhoods with a non-Hispanic white majority. On the right, we illustrate our dead vaccination gap that I mentioned earlier. For this gap, the areas in dark red indicate areas with the biggest gap, which represent areas with high COVID-19 deaths but low vaccinations. And areas in green indicate small dead vaccination gaps, which indicate areas with low COVID-19 cases but high vaccination rates. So when we compare both of these maps, we see that areas with Hispanic racial majority are also areas with the biggest gaps in COVID-19. So this shows how the gap is unevenly distributed, especially in that Hispanics reside in neighborhoods that have been less served by vaccination, which put them at higher risk of COVID-19. We conducted a final set of analysis to understand in what type of neighborhoods Hispanics tend to live. Overall, we found that regardless of age, race, or ethnicity, Hispanics tend to live in neighborhoods with a higher risk of COVID-19. As illustrated on the graph on the right, more than 50% of the Hispanic population lives within neighborhoods with a high or highest dead vaccination gaps. This is not an indication whether or not someone will actually get sick of COVID-19, but it is about the chances of getting sick or the risk of getting sick. For example, if someone lives in a neighborhood with a high level of pedestrian accidents, it doesn't mean that they will necessarily get hit by a car, but that they are more likely to get hit by a car. We could further looked into the chances of non-Hispanic whites to live in neighborhoods with higher risk of COVID-19 across people who were 65 years or older or with high levels of education. And we find that among these groups, there's also a higher risk of death and lower vaccinations. Furthermore, we looked at differences among Hispanics based on their ethnicity. So we looked at Dominicans, Mexicans, and Puerto Ricans, and we found that across all these three groups, they all tend to have live in neighborhoods with high risk of COVID-19 death, but low vaccination rates. So just overall, we find high levels of disparities between non-Hispanic whites and Hispanics. And this is even after controlling for age or education and also ethnicity. So what does this all mean? So this shows that the public health crisis is systematically reproducing pre-pandemic inequality. It also, we hope that through these findings, we're able to highlight the importance of vaccinated individuals and predominantly Hispanic neighborhoods to lower the risk of getting COVID-19. And we hope that it also highlights the importance of continuing to investigate COVID-19 vaccination and how it's impacting other racial groups, especially non-Hispanic Black New Yorkers. We will be releasing a report with this information in mid-May. In the meantime, you can contact the Center of Need for Knowledge or the Latino Policy and Politics Initiative to get more information. We will also be making this PowerPoint available. Thank you.
Thank you, Natalie, for the interesting presentation. I think if something is indeed significant about the work you presented is that it makes clearly the point that geography matters. Your point about how the pandemic inequality we're observing is just reproducing the already existing inequities is an important one. Now, I had the privilege of being able to see some additional analysis from your group that show, for example, how the percent foreign born in the neighborhood, the percent over 65 in the neighborhood, the percent disabled, and percent with less than a bachelor's degree in these neighborhoods made a difference. So it's truly how all these indicators converge in these neighborhoods to create a very problematic situation. So could you speculate a little bit about next steps in the analysis and hopefully what do you think the contribution that it will make?
Yes, thank you. And thank you so much for allowing me the opportunity to present today. I think talking about the factors that you mentioned, including people with like lesser education, people, higher percentage of people that are born from outside the US, I think that this brings the questions about the type of information that's available. Like, is COVID-19 vaccination data available in all languages? I think a big thing to think about too is thinking about the requirements for IDs. How accessible are the COVID-19 or are the vaccination sites So even if we did some analysis looking at how closeness to a vaccination site affected vaccination rates, and we didn't see any differences. But I think that gets more to the point, what times, like having to make an appointment can be a big barrier for people who might have jobs that don't allow the flexibility to book in advance. Thinking about people with disabilities, a lot of times moving around New York City, a lot of the work that I was doing before was with people that had different types of mental or physical disabilities that require using paratransit services. Booking those services might not make it possible to get an appointment at a time and might be lowering the rate. So I think there's, first, it's really important to just add more resources into neighborhoods that have this debt and vaccination gap. And I think it's just working more with communities to see how to improve transportation and education about the vaccine, as well as like making the vaccine appointments more flexible in order to hopefully get everyone vaccinated and lower the risk of COVID-19 infections.
So what I would like to do now is go quickly over a number of sort of key takeaways from the presentations that we've heard today. And I think that something that it has become apparent is that the COVID-19 is not just a cause of significant problems in terms of mortality, in terms of potential impact on comorbidities, but it's also a compounder of inequities. In other words, that some of the ways that it's working into consequences for the Puerto Rican population has to do with existing inequities that may impact access, may impact language ability to communicate, access to resources, social networks, the impact that being unemployed or a family member in the family, losing a job. For example, access to food care and things of that, food insecurity, inequities that already were in place. What COVID-19 is essentially exposing and reproducing those same inequities during the pandemic. Some key takeaways that both have some implications for Puerto Rico is that COVID-19 is amplifying the already problematic challenges for the island in terms of the long-term economic crisis, the catastrophic effects of Hurricane Maria, the earthquakes that they experienced in 2019 and 2020. In general, during that whole period, a culture of neglect at the federal level, where efforts to support the island and fund efforts that would lead to getting the residents of Puerto Rico out of the crisis just went by the side of the road. There was essentially very little interest on investing in Puerto Rico. In addition, it has further exposed the structural deficiencies of the island's health system, became very apparent during Maria, partly when it came as to availability to electrical supply or to clean water. But the impact of that has also been experienced as part of the impact of COVID-19. Second, I think that some of the compounding of some of the health consequences due to the high incidence of comorbidities in the Puerto Rican population, both on the island and on the mainland, as has been documented by the BPRHS study in Boston and now by the Prospect study in Puerto Rico. Diabetes, cardiovascular disease, hypertension, obesity, the high incidence in the Puerto Rican population, those are all factors that have been associated with more significant consequences if you do experience a COVID infection. In addition, Dr. Matei has been the point very clearly how you don't have to experience a COVID infection for COVID to have consequences on psychosocial stress, on symptomatology of depression, of indicators of stress in general, and a general sense of social isolation. So it's important to keep in mind that the impact may be indirect, but it's still considered to have an impact on the Puerto Rican population. Also, the pandemic has exacerbated challenges with access to medical care and food security. Food security both on the mainland and on the island, as we have reported in previous research, are a challenge for a significant percent of the Puerto Rican population. And then my next point has to do with sort of trying to understand the significance of some of the key points here. Essentially that COVID-19 cases, either death rates or cases in the general population truly do not capture, even the vaccination rates do not capture the impact on the population, the impact of the pandemic on subgroups within the population. As Natalie pointed out, the convergence of negative factors at higher levels in neighborhoods where Puerto Ricans and other minorities live have clearly has some serious consequences for rates of infection and for access to vaccination, which are significantly different from those of non-Hispanic white. Also, the point that I think it comes across all three of the presentations, that death, while it is a terrible outcome, is not the only consequence of the pandemic. This pandemic is going to impact way more people than those that we lost to the pandemic. And that vaccination is a way out of the pandemic itself, but it's not a way out of the byproducts of the pandemic. We need to keep in perspective that this pandemic will have not only physical but emotional consequences for this population, and that, as Josie Matei pointed out in her presentation, we need to consider what are the critical interventions that we need to be made and prioritized in order to begin to address some of these challenges. There's essentially no literature right now on this problem, particularly when it comes to impact on Puerto Ricans. I did a search of the current literature. I found 3 publications at this point that talk about COVID and Puerto Ricans, and they're all in the similar stage to some of the presentations that we heard today, where data are being presented from symptoms that were registered back in summer or fall of next year, before the intensification that we saw in the incidence of cases and increase in mortality that was experienced from November forward. So I hope that you keep in mind these key takeaways as we go into the section for questions. I will stop here so that we have an opportunity for those in the audience to ask questions of the panelists. Thank you very much.
Thank you, Luis. I actually wanted to remind members of the audience that the presenters will be fielding questions presented to them through the Q&A function in Zoom, you found at the bottom of the screen. I would also like to invite our presenters, Dr. Matei, Dr. Mangano, and soon I hope to be, we hope she'll be Dr. Natalie Rios, to come on the screen so we can ask a couple of questions of the audience. The first question is a question of clarification for Natalie. And the question reads, Natalie, are you referring to COVID positive cases and survivors to the COVID Centers of Excellence in New York City? So can you specify a little bit about specifically the population that you're analyzing? COVID positive cases and survivors to the COVID Centers of Excellence. That's question number one. Then there's also a couple of questions that are more broad that could apply both to the case in New York City as well as the case in Puerto Rico. It says, have you looked and found differences between Puerto Rican or Latino recently arrived to the United States compared with those who have been in the United States longer? So let's take those two questions. And Natalie, if you could please address the first question And then Josimer and Natalie, you can address the second question. And then I have another question for Kelsey later on.
Yeah, no, the data is for all of New York City, and it comes from the Department of Health. So it's not as specifically from the COVID Centers of Excellence. So it's just data from the NYC Department of Health. I hope that's clear enough. I can also give more detail if needed.
And then in terms of the recency of migration, what impact might the recency of migration to the United States be reflected among Puerto Ricans and other Latinos, perhaps in New York City, and perhaps have we seen some differences as such, Dr. Matei, in regards to Puerto Ricans on the island, in regards to migration? Natalie, if you may.
Yeah, so we unfortunately did not look at any data on how long people had been in the US for. Just in general, like whether or not they were born here or not. I do suspect there is probably some challenges, like a lot of the vaccine sites are in like local community centers, so people don't have access to them or don't know about them. I can see that being a potential issue.
Dr. Matei?
Yes, I'm going to quickly mention that in Prospect, we do track migration. We have not done that analysis yet. There was obviously very little move back and forth during COVID because of the travel restrictions in theory, but anecdotally, we know, and from tracking through other surveillance systems that I have been involved in the island, especially with the Ponce Health Sciences Institute School, we know that people were indeed traveling and had a lot of Puerto Ricans moving, especially from the Florida region back to the island when things got better, and then moving back to Florida when things got a little bit harsh in Puerto Rico. This needs to be documented much better, and that's something that we will be working on because we have the data, but I cannot unfortunately answer that question fully. I'm going to deflect this to Kelsey because I know that we do have more data on migration and back and forth in the Boston Puerto Rican study.
Okay. We are getting comments or questions from the audience asking if the slides will be posted on our website. And this is a reminder to all the members of the audience that yes, the entire webinar will be available after a couple of days for your viewing, as well as the individual presentations presented here. One question for Dr. Mangano. I couldn't help but think that the data, you had 504 members in your samples, individuals in your sample. 7 had passed. 21 had become infected. This leaves proportions of about 1.4 deaths, based on a 504 sample, and then a 4% infection rate. How does that compare to other residents in the Boston area? So how do Puerto Ricans or how do Hispanics in the Boston area compare given these mortality as well as morbidity rates?
Well, thank you so much for the question. First, I'll quickly answer Josie's toss over to me that we did measure acculturation status in the Boston Puerto Rican Health Study, and we did not find acculturation status to differ between the small number of individuals who reported being COVID-19 positive and those who did not report experiencing the disease. That being said, we have a very low acculturation status in our population, so I'm not exactly sure if the comparison is fair, but we do have the data and we'll continue to follow up on that and report on that. So thank you for the question. And to answer the question regarding the rates of death and infection, I have to say I'm not exactly sure, and I don't mean to put you on the spot, but if Josie or Dr. Falcón have another I believe that death rate and infection rate is higher compared to other communities. But to be honest, I haven't seen a lot of data published yet in other communities, so I'm not sure I can make a fair assessment.
What we do know is that the rates are much higher, nearly double in the communities and the Boston is divided in cities and towns, so it's very clear-cut rather than districts or regions. And in the cities and towns that are more populated by Latinos, and most of our communities are Dominican and Puerto Ricans, there's a doubling in infection rates than in the other cities, especially in the high-income cities.
And this raises, Dr. Falcón.
Yeah, no, I was going to say absolutely that Josie is correct. The rates for Latinos in Massachusetts are much higher than for non-Hispanic whites. And in fact, it caused the governor to change their strategy for vaccination at the state level and begin reallocating vaccinations to communities with high risk. They had done the same earlier on when they were doing testing for COVID. They reallocated resources. For example, the city of Lowell, every resident in the city was asked to go out for testing, even if they had symptoms or not. The same was done in Lawrence. So they targeted a few cities that had significant minority populations and said, let's test everyone and figure out who is contagious and who is not. Yeah. So there have been some efforts because there are significant disparities between Latinos and non-Latinos in the state.
Yeah, it's also interesting because, of course, you know, there are two different trends that we may need to contend with, because on the one hand there is this whole immigrant paradox in which immigrants into the United States tend to have healthier or better health outcomes than say Latinos or immigrants that have been in the United States for a longer period of time, but we have also seen a prevalence of or greater incidence of both morbidity and mortality among Latinos and, you know, in this case, Puerto Ricans as well in the United States. At the same time, there is the whole issue, and one of the comments from the members of the audience is that age seems to be a much more salient variable. And we know that, for instance, in New York City, the Puerto Rican population is older than Puerto Ricans across the United States, but that is not necessarily the case in Massachusetts, where the Puerto Rican population is much younger than nationally. So I wonder to what extent age may have, you know, to what extent age is an important variable to look at. You know, we have seen that the mortality among the older cohorts is greater than among the younger cohorts, but then we have to look at the impact of workplace exposure, having to, you know, be essential workers and things of this nature. And I open it up to anybody in the panel.
Well, a couple of points. One, I think age as a factor is critical because age has to do with the life cycle, and it sort of differentiates what your activities are at a given point in time. Take Massachusetts, for example. A lot of the mortality for the population 65 and above actually took place in assisted living facilities and retirement facilities, something that the Puerto Ricans in general tend not to have access to or the resources to be able to afford those. So the fact that Kelsey has found a fairly low incidence of COVID infection in the population in some ways speak to the protectiveness of not being in a particular income bracket. On the other hand, what you're starting to see is significant rates of infections among the younger age groups in the population. And that has to do, one, that for some of the Latinos, particularly Puerto Ricans, they never left the job market. They continue working day in and day out. A number of them in the health sector, which is, I believe, the third largest employer in Massachusetts. A lot of them that were working in health facilities without protection continue working day in and day out. In the service sector, same thing. So they had more exposure to activities that could lead to higher rates of infection. So yes, age is a critical factor because it does expose you to different activities.
Quick adding to what Luis just said is that it was very interesting because Kelsey, for example, reported a much higher number of cases that were reported in the Boston Puerto Rican, and that is an older cohort compared to our cohort in Puerto Rico, where the mean age was around 50, 51, 52 years old. So this is important, and it speaks precisely to that difference in age, even though the age structure in Puerto Rico tends to be older. And one quick reminder is that that was the situation a few months ago. And something that we have to remember is now in Puerto Rico, this is flipping. And most of the cases that we're seeing right now is actually in younger populations in the 20s and 30s, and even in adolescents. So that we have to be vigilant that yes, even though the pandemic started with mostly in the older generation and in the older population, this can shift, and this can shift at any moment.
Anybody else? Then a question for Dr. Matei, and this is in regards to trauma. The trauma that COVID itself inflicted upon the population. But of course, as we all know, COVID is just the latest in a series of catastrophes affecting Puerto Rico. The earthquake swarms in the southwest coast of the island, both Hurricane Irma and Maria, prior to that, the economic crisis. And I know that the prospect started in 2015, but I wonder to what extent what cumulative effects on mental health there may be as a result, and how can that be captured?
Yes, it can be captured, and that is something that we are measuring. As I mentioned, we have a very solid and comprehensive battery of several emotional and mental health, and that includes post-traumatic stress syndrome, including reasons for that stress. Is it violence? Is it adverse childhood violence and crime or events? Or is it the events that have been happening in the society? So we will be able to track that throughout times. And I have to say, Prospect, as Luis said, has been a survivor among all of these. We started right after Maria, like right after.
Seem to have a technical delay.
Track throughout of this, and we even have data during the earthquakes. So we should be able to see how these things have been shifting. And the other thing that we have been measuring are biological markers of stress. So we have markers on cortisol, for example, both from urine, from hair, which are very strong markers, and we should be able to see if this indeed has been shifting throughout these events and how it has been shifting. And more importantly, we have positive measures, measures of positive emotional health, resiliency, coping mechanisms, social networks, social connectivity, which we think are very strong buffers of this distress. So that's something that we also want to see, because we know from qualitative work that we have done that this distress is happening, but at the same time, social support and resiliency is also increasing. And I think that's the positive message that we have to keep in mind, that yes, there is distress, but there are also strategies and mechanisms that we can pull from within our community to avoid that.
Another question that stems from a query from the audience is in regards to ancillary issues that may be affecting physical health and perhaps mental health, and this refers to food quality. What impact may food quality, whether in Puerto Rico or among Puerto Ricans in the United States, affect a person's health, and what interventions may there be to address the issue of food quality for the Puerto Rican population?
I can start and then turn it over to Dr. Matei or anybody else who wants to add. We do know that food quality has a significant impact overall, pre, post, during pandemic on our immune response. So it's very plausible that poor dietary quality would lead to a poor immune response, which could in fact affect an individual's ability to recover from disease, certainly. And that's why we also asked questions in our Boston Puerto Rican health study surrounding food security. We know we have rates and unmet needs of food insecurity in our population. Interestingly, and I think not just in our cohort, we saw a shift due to the abundance of, at least in Massachusetts, the abundance of food that was required through assistance programs in the state immediately during that first summer following the initiation of the pandemic. However, some of those resources have now run out. And so we anticipate that with our follow-up study, we may see increases now in food insecurity among certain pockets, particularly among Puerto Ricans and Massachusetts. So that's certainly something that we're monitoring for.
I'll add very, very briefly. Yes, we are tracking changes in eating and especially responses to emotional eating. So we have specifically how people are responding to these emotions through eating behaviors. What I can say is something that Luis mentioned before and that we really have to stress is that whatever pandemics, whatever disaster happen, will exacerbate what is already happening in the island. So the issue is that in the island and in our Puerto Rican community, we already had poor diet quality, poor intake, a lot of nutritional deficiency, especially in important vitamins and minerals, and high food insecurity. Almost half of the population in Puerto Rico is receiving the equivalent to SNAP, so food assistance. So the situation is really that we have to pay attention to this at all times, because when something happens, it's just gonna make it worse. So yes, we have to respond now, but then we can just not drop the ball when COVID is gone or when the hurricane is over. We have to be vigilant and we have to have these policies in place for all times. And the thing that I will highly recommend to help improve this is widening food assistance coverage and ensuring that people have access to food assistance.
Thank you. As it tends to happen in presentations such as this, now there are many more questions that there's time to answer them all. But I invite all of our presenters to continue answering and responding to some of these questions in writing through the Q&A as we move on to the next presentation. But I am going to field one more question before we conclude this segment of the webinar, and it is regarding vaccines. Two related questions. One says, it seems to me that vaccines have been more accessible here on the island than in the US. Is that the case? Question number one. And then related to it is, aside from the general distrust minority populations have in getting the vaccine, do you find that the Johnson & Johnson pause affected Puerto Ricans and other minorities in getting the vaccine? Will there be any studies to compare minority populations' usage of the different vaccines? If anybody can answer those questions. And if you don't, that's fine.
I think I responded already in the Q&A to one of these questions, which was precisely about vaccine intent and vaccine hesitancy in the island. A very good colleague of mine, Dr. Andrea Lopez-Cepero, who is also a collaborator in the Prospect study, she did a population-wide survey precisely on vaccine hesitancy and intent in the island. And vaccine intent was really high. It was over 80%. Those results are going to come over soon. I think that might explain why we're seeing more vaccination and higher vaccinations rate in the island than here. I cannot speak too much about, whether we're receiving the vaccines or not, but definitely the hesitation, the intent is pretty high. Those results are going to be published soon.
Anybody else?
Yeah, Carlos. I'm a sociologist, so I can always speculate. What I was going to say is that clearly conditions on the ground vary across the states. I mean, there are states where you can sign up for a vaccine and you're not going to be able to know what is being administered. So when you show up at the site, that's, they give you what they have. In Massachusetts, for example, there are large sites that you actually can choose the site based on the vaccine that they're providing. So there is some options to choose. Certainly, the J&J delay will have an impact across the board for the country. I think it will be hard to separate, and it was going to require perhaps data accessibility that we may or may not have from the CDC. I mean, the CDC is keeping records on the different types of vaccination administered. And I know in Massachusetts, for example, when you fill out the information for the vaccination, it asks you for identifiers on race and Hispanic origin. So if the state were to make that available, we would be able to identify distribution of different vaccine types across the population. But it's going to require a concerted effort from state offices to be willing to share that information.
Well, thank you, Dean Luis Falcón, our moderator and discussant, as well as our presenters, Dr. Edwin Melendez, Dr. Kelsey Mangano, Dr. Josimer Matei, and soon to be Dr. Natalie Rios, for tremendous presentations. Everybody should know that all of these presentations will be available in our website, centralpr.hunter.cuny.edu, as well as recordings of the webinar. To cap today's webinar, we are going to be unveiling and demonstrating a research tool that the Center for Puerto Rican Studies has developed and is making available to the public in general, Centro's COVID dashboard. And for that, and to explain the details of the dashboard, I want to invite my colleague Jennifer Hinojosa, who is a research associate and the coordinator of the Centro's Data Center, to join us and make this presentation.
Good afternoon. For the past couple of months, we've been working on creating an intuitive dashboard to provide a greater understanding into how COVID-19 pandemic is unfolding across the nation's communities, especially on communities with large concentrations of Puerto Ricans in the U.S. As we've seen across studies and media, the COVID-19 pandemic has disproportionately impacted communities across the nation, especially in Hispanic and non-Hispanic Black communities. The overview for my presentation is as follows. I will do a quick overview of the dashboard's data, layout, and functions, followed by a quick demo analyzing local impacts of Puerto Rican communities in New York, and if we have enough time, for Massachusetts. I will then end it with a Q&A. Let's get started. As outlined in the figure below, our dashboard integrates various data sets. The list of variables and sources methodologies can be found in our website's toolbox or underneath the graphics within the dashboard. The variables are categorized in the following: social impact indices, which include severe housing, economic vulnerability, food insecurity, inadequate facilities, and digital divide index. Then we have the COVID Community Index, CCVI, which includes healthcare facilities, high-risk environment, and CDC Social Vulnerability Index. We then have the risk exposure, which we've broken down by different ethnic groups for non-Hispanic Blacks, whites, Puerto Ricans, Dominicans, Mexicans, and Cubans. Then we have the COVID-19 data, which is updated daily, and it includes COVID infections, COVID deaths, percent vaccinated adults, and ability to handle a COVID outbreak. Lastly, we have census data, which includes overall population, percent of the population that are 65 years and over, percent uninsured, percent below poverty, and lastly, population by race and ethnicity, and Hispanic and Latinos by subgroups. The general layout of the dashboard is as follows. So it's a lot of information, but I think it's important to sort of know the layout. On the left-hand side, we have indices sliders, which is connected, so which is this part. In the dashboard, it looks like this. These sliders are connected to the interactive map and layers. I will discuss this a bit further during the demo. Above the map contains the general information related to the geography or the selected geography's total population and other characteristics. Population by race, ethnicity, and subpopulation Latino groups is located on the upper right side of the dashboard in the form of pie charts. So it's located here. The social impact indices, COVID impact community index, and risk exposure index is located on the lower left side of the dashboard in the form of bar charts. Lastly, a temporal line graph below the map contains the COVID cases and deaths for the last 14 days and 12 months, which is located here. Now let's look at a macro level analysis before we get into the local analysis. So here we have the dashboard. And we have the pre-selected layer that you see now is the COVID infections rate. And if you want to change that layer, so we have all the layers listed here. Okay. And let's deselect the COVID infections and select the risk exposure index for Puerto Ricans in the US. Okay. Now let's see what the breakdown is. So we see here risk exposure. So the darker the shade is, so red and orange signifies high, moderate to high risk exposure. So as we can see here, the Northeast, parts of the South, and West Coast counties with Puerto Ricans' high risk exposures. We see a lot of those counties with high risk exposures. And you could play around with the sliders here on the left side. So if you want to look into specific counties with high COVID infection rates or with high COVID death rates, you're able to do that as well. So here we have, okay. Now let's look at counties with with a moderate social vulnerability index. So we select that, or a very high social vulnerability index. So we have some of those, not only high Puerto Rican risk exposure index, but also high social vulnerability index. Okay. Now let's look into an in-depth look of Puerto Ricans in New York State. So just for context reasons, New York State had the second largest concentration of Puerto Ricans in the US, with an estimated population of 1 million, with the majority of Puerto Ricans residing in Bronx County. Puerto Ricans account for about 6% of the state's overall population. There was a slight increase between 2018 and 2019. Okay. Now let's navigate this by selecting New York State. Let's click on Puerto Rican concentrated states. You will see the 13 states there, but we only want to look into New York State. So now let's filter this out from New York. And again, the pre-selected layer here is the COVID infections. But we want to look into the Puerto Rican risk exposure. So again, the bar charts and the general information above changes according to the selected geography. Now let's change this. Oh, here you have your layers. Let's deselect the COVID infection layer and select the risk exposure. As we can see here, and we have the legend right there. We see the high risk exposure amongst the Puerto Ricans in the New York State region, New York City region, Long Island, downstate, and parts of upstate New York. And as you can see here, we have the information that changes. Now let's look at areas or counties with a very high social vulnerability index and a high Puerto Rican risk exposure. Okay, so we see parts of downstate. Here we have Monroe County and parts of New York City region counties that it picks up. Let's reset this. Let's look at housing cost burden index. So it will select the counties with a very high cost burden index. So again, we see parts of New York City region, upstate New York. But let's take a closer look at Bronx County. So we'll zoom into Bronx County. Here's some data, COVID data related to Bronx County. We have the breakdown of the Hispanic subpopulation group and population by ethnicity. Now let's look into the indices. Okay. Let's open this up. We also have the COVID deaths, cases for the last 14 days and 12 months. Okay. Now let's look at Monroe County. That was the other county with a very high social vulnerability index and high housing cost burden. So again, we have the information here that relates to the general population in terms of COVID cases and deaths, social impact indices. So you can see here, right? And I know I'm going a little fast, but I think I'm running out of time. But again, all of this is available to you. We see that Puerto Ricans and Dominicans have a very high risk exposure. I think that's about it. I'm pretty sure we're gonna have a much longer demo, but for the sake of time, we're gonna have to cut it a bit short. And here is my information. If you have any questions, do not hesitate to contact me. Thank you.
Thank you very much, Jennifer, for a great presentation of the dashboard. If you can come on live so we can field a couple of questions. Jennifer?
Yes.
Who is this dashboard for? Who is this designed for?
It's designed, can you hear me?
Yes.
Okay. The dashboard is designed for the policymakers, researchers, perhaps to the general public to look at the inequality when you look at things from a spatial perspective. We tend to focus more on numbers in terms of death rates, COVID infection rates, right? But with this dashboard, we really thought it out. And first, if I could stop, I'm gonna also thank my team, Paul Bendernagel, Alex De Leon, and Damaida, who we've worked very hard on putting this dashboard together. And there was a lot of thought process into it, right? What information do we need from at a local level? So not only just look at numbers related to COVID death rates or infection rates, but I think something as food insecurity, percent of the older age population, economic vulnerability, or CDC social vulnerability index would be as important to look at the I guess the environment in which Puerto Ricans or non-Hispanic Blacks, whites, and other Hispanic groups live in. So it gives you a really nice, it depicts a nice, overall picture of different groups, but more importantly, the different geographies that plays a role.
Yeah, and of course, for this to be useful, we need to have current data. So can you speak a little bit more to how current the data that people may encounter in this dashboard is?
Right. So again, we've curated a lot of the data in terms like we had third-party data as well as data that we calculated in-house. So for example, the COVID infection data and death, and I believe the percent of the adult population vaccinated was from the CDC. And this is updated daily. And other indices, for example, the population general characteristics such as total population, percent of the population above 65 or below the poverty level, those are from the 2019 ACS. So again, we will have a table that outlines the name of the variables, the sourcing, and the data as, in terms of the year that data is as of. But again, we will have all of that in our toolbox. And also if you go into the dashboard, and it's still in the beta phase, so we're still refining it. So any comments or suggestions as well, it's welcomed. But all of that data sources is underneath the dashboard. So if you look at the pie charts, you will have the methodology listed there, the links to where the data belongs to.
There's a question, any efforts to share the dashboard with media and local organizations in Puerto Rico?
Sure. I mean, we are now in the process of designing a similar dashboard, but for Puerto Rico. So that's in the works, and hopefully we will release that sometime next week. But that's still in the process of.
Yeah. Another question, in addition to timeliness, is about the reliability of the data. Can you speak to the reliability of the data that is used and contained in the dashboard?
So, for example, obviously the pandemic happened in 2020 and 2021. So we can only, have access to data that's, for example, for the 2019, the U.S. Census Bureau, the latest data that they have available in terms of broken down by county level data is the 2019 5-year estimates, right? So, I mean, we have everything laid out in terms of the sourcing. CDC data, I mean, that data is obviously from the CDC and it's updated daily. But in terms of reliability, I mean, we all depend on different sourcing of data, but everything is listed there.
Terrific. Right now, the data is in English. Translating into Spanish would probably be a big lift. Hopefully, what efforts will there be, particularly if we submit it for use in Puerto Rico?
Can you repeat that question?
Yeah, no, basically about translating the dashboard. It is something that would give a greater exposure, I suspect.
Oh, definitely. I mean, that's something that we could definitely look into. We could definitely test that out, and I think it would be amazing to have such a dashboard, including like how-to guides and how to use a dashboard. So we're trying to make it more user-friendly. It's a lot of information, but we're definitely we'll definitely take that up to my team.
And one last question before we close out this afternoon, Jennifer. What other types of data does the data center have?
Oh, we have data sheets that includes if you want to look at a specific state or county. We have socio-demographic data for the states, as well as I think the director, Dr. Melendez, presented a data that we pushed out, data sheet related to the COVID-19 pandemic to small businesses in Puerto Rico, and we are hoping to have an updated version of that. So we have many different research briefs and policy briefs. But this is something that we're gonna push out.
Okay, terrific. Well, Jennifer, thank you. Thank you very much to you and the team that has put this dashboard together. I know it's gonna be great, of great use for all interested in these times of COVID and beyond. I also want to remind the audience that you can find this dashboard and all other information about the products that the Centro puts out in our website, centropr.hunter.cuny.edu, where you can find these presentations as well as previous webinars. You can also find information regarding the webinars in the Nation Builder page for Centro, centropr.nationbuilder.com. I would also like to mention that we have another webinar scheduled for 2 weeks from today, almost 2 weeks from today, on May 12th. We will be having a Meet the Authors event with Federico Subervi Vélez, Sandra Rodriguez Cotto, and Jairo Ocando, who will be discussing their brand new book, The News Media in Puerto Rico, Journalism in Colonial Settings in the Times of Crisis. Please, stay tuned for that webinar. Join us for that webinar. It promises to be as great as this present webinar has been. And with this, we conclude our webinar for this afternoon. Once you log off, you will receive a brief survey on how to improve our interfaces. So please, fill it in if you so kindly would. And, again, thank you to all of our presenters, Dr. Edwin Melendez, Dr. Kelsey Mangano, Dr. Josimer Matei, soon to be Dr. Natalie Rios, our colleague Jennifer Hinojosa, our hosts and moderators, Dean Luis Falcón, Paul Ong, and Rodrigo Dominguez Villegas. With this, I wish you a good afternoon, buenas tardes y gracias.